Hello, anatomy colleagues. Let's finish our conversation regarding the neck and back regional musculoskeletal anatomy with a conversation of some of the main muscles in this region. And since we're talking the neck and the back, that's a fairly large area. So we're going to kind of span quite a few muscles, starting with the sternocleidomastoid, the trapezius. Then we're going to kind of talk of the supra and the infrahyoid muscles as those groups. We're not going to get into the individual muscles there. We'll talk a little bit about the anterior scalene muscle, particularly its importance in certain anatomical relationships. Then the erector spinae muscles, which are some of those deep back muscles. And last but not least, we'll talk about the latissimus dorsi. So let's start with the sternocleidomastoid muscle. And this is one of the most dominant muscles in the anterior lateral neck, and you can actually palpate your sternocleidomastoid muscle, as well as you can oftentimes see the sternocleidomastoid muscle through the skin, or at least the shape of where it would be located. So I always kind of like to tilt my head to the opposite side, and you can really palpate almost the entire length of the sternocleidomastoid. Now, what's super cool about the name of this super long muscle, which I remember when I was learning this muscle, I thought, you've got to be kidding me. This name is ridiculous. But it kind of tells you exactly where this muscle will attach. And oftentimes you'll see sternocleidomastoid muscle abbreviated SCM. So the sterno is indicating that there is going to be an inferior attachment to the sternum. The cleido, specifically the manubrium of the sternum. The cleido is indicating the clavicle, so you can see a fairly large attachment to the clavicle. And the mastoid is going to be the more superior attachment, which will be up here. And that superior attachment will continue posteriorly to also attach on the occipital bone. So a fairly large, prominent muscle. It will help kind of subdivide the neck into the anterior neck, and then behind this would be the posterior neck. And so these are crossing these cervical vertebral joints. So if you have that direct crossing, it can directly affect the actions in that region. And so it's dependent on whether both sternocleidomastoids are contracting at the same time or just one. So if there is a bilateral contraction, so both the left and the right are contracting, quite a few things can happen, but the one we're going to really focus on is the flexion of the cervical vertebrae, or neck flexion. So you can kind of think of specifically kind of that chin flexing or bending and heading more towards the manubrium region. So that would be flexion of the the cervical vertebrae. Whereas with unilateral contraction, on the side that's contracting, so say we're contracting here, this is patient right. Say the right sternocleidomastoid is contracting. With lateral flexion, you would have flexion on that same side. Kind of think of flexing with that coronal plane. So think of putting the head kind of towards the shoulder. Also, you can have rotation of the head in the opposite direction. So I kind of think of if you put your head on the same side of the shoulder and then kind of tilt your chin up, that's what we mean by that rotation. Sternocleidomastoid is unique, along with one of the other muscles that we'll talk about in this video, that it receives its efferent or motor fibers from a different nerve than the afferent, or that has afferent fibers or sensory fibers. Usually you'll have one nerve that provides both the afferent and the efferent, but that is not the case here. So efferent is the motor. That's typically what we think about when we're thinking about innervation of muscles, and afferent is the sensory. So the efferent innervation will be the accessory nerve, or cranial nerve 11. And this is a purely motor or efferent nerve, so it makes sense that it cannot provide any of the sensory innervation or kind of that proprioception, or just being aware of the location of this muscle or if it's contracting. and it will get those afferent fibers from the from fibers of the cervical spinal nerves of C2 and C3. All right, moving towards the back region, so we're looking at a posterior view here in this illustration. You have the trapezius muscle, which is a superficial back muscle. You see it's kind of a trapezoid shape. It's going to have fairly expansive origins and insertions or different attachment sites. So the more superior attachment here or an inferior attachments here. You can see that terminology is kind of sneaking in there. So the external occipital protuberance, which is that bump that we talked about on the occipital bone, will have, that is where the trapezius will attach, as well as kind of expanding on either side of the occipital bone. There'll also be attachments more along the midline, along the spinous processes of C7 to T1. And then the insertions will be more inferior or distal, because you'll have insertions on the clavicle, which you can see here, but the trapezius has been reflected on this side, but you would have it extend over there, as well as on the acromion of the scapula and the spine of the scapula. So you can see it's attaching here. It has more distal attachment here, so when this muscle contracts, it's going to directly affect the movement of the scapula. And similar to what we had with the sternocleidomastoid, it will receive efferent innervation from the accessory nerve. So the accessory nerve is cranial nerve 11, and it only does two things. It will provide efferent innervation to the sternocleidomastoid and to the trapezius muscle. The trapezius muscle will get afferent fibers from C3 and C4 typically. But really, while this is cool, I don't care as much that you remember this, other than the fact that it gets its afferents from a different location. I really want you to focus more on the accessory nerve, and same thing here for trapezius. Now, as mentioned, when the trapezius contracts, it will directly affect the movements of the scapula. It does not cross all the way the shoulder joint, so it's not going to directly create actions at the shoulder joints, but the actions that occur at the scapula will allow a full range of motion at the shoulder joint. So it's pretty important in that way. So the trapezius muscle will have fibers that are going into many different directions. So depending on which fibers are contracting, it could either elevate the scapula, as you can see here, so kind of shrugging your shoulder, or depress, so it's antagonistic to itself based on which fibers are contracting. It can also retract the scapula, and that's moving this medial portion of the scapula more towards the midline and sometimes even past that. And then very importantly, it can also cause the scapula to rotate superiorly, specifically this upward rotation of the glenoid fossa. And so that allows for the scapula to almost tip upwards, which will allow a full range of motion at the more distal shoulder joint. Okay, returning to the anterior neck, so we're keeping kind of superficial. The sternocleidomastoid is right here, just for context. And then we're going to head more towards the midline to these smaller muscles here. And really the key to both the supra and the infrahyoid muscles is understanding where the hyoid bone is. Remember that's that free-floating bone in the anterior neck that's going to be superior to the larynx, which is right here. And the suprahyoid muscles will all be located, the bellies will all be located above or superior to the hyoid, whereas the infrahyoid muscles will all be located inferior to the hyoid. And almost all of the supra and the infrahyoid muscles will have some form of attachment on the hyoid. Now, and based on their location, if you think about these muscles right here contracting, it would kind of pull up the hyoid or elevate the hyoid. Whereas with the infrahyoid muscles, if those are contracting, it would pull the hyoid bone down. And dependent on whether some of these infrahyoid muscles or strap muscles are also attached to the thyroid cartilage, they can play a role in terms of depression of the larynx, and one can even play a role in terms of elevation of the larynx. But that's really important in terms of allowing certain things to kind of be in the place they need to be to allow for efficient swallowing and speaking. And one thing you can see in both the supra and the infrahyoid muscles is that they can play a role in terms of supporting and keeping the hyoid bone still. And that has a lot to do with allowing for swallowing and speaking to occur efficiently. The next muscle I want to talk about is the anterior scalene muscle. And the anterior scalene muscle, in terms of when it contracts, doesn't play a huge role. It plays a small role in terms of respiration, allowing the ribs to move to allow for the thoracic cage to change in shape. But really what's more important in terms of relationships is how close it is to certain structures. And so it actually will play a really important landmark role for the subclavian artery, which is this artery right here. And you can see the anterior scalene coming just superficial or anterior to the subclavian artery, and it actually will subdivide the subclavian artery into a first part, if it's medial to it, a second part, so the subclavian artery deep to the anterior scalene, and a third part, the subclavian artery lateral to this. And you'll talk about this relationship a bit more with Dr. Fox when you get into the vasculature. But that close relationship with the subclavian is important. Additionally, it's very close to the brachial plexus, which is, you can see some arteries kind of going over the top, but all this right here, these are all components of the brachial plexus. And the brachial plexus is hugely important in terms of the innervation of the upper limb. All right, now moving to the back, and we're kind of jumping all over the place. I tried to go from more superficial muscles to deeper muscles, even though I am ending with the latissimus dorsi, which is fairly superficial, but I'll talk about why I did that in a moment. But when we get to the back, we have the large trapezius muscle that we saw a moment ago. We'll have the latissimus dorsi muscle, which you can see just as kind of a sneak peek. Here's that trapezius, and here is the latissimus dorsi. If I were to reflect these muscles, I would be looking at these deeper back muscles, and this is kind of a whole complex of muscles referred to as the erector spinae muscles. And these muscles are really important in terms of extension of the vertebrae. So kind of thinking of standing back upright, back in anatomical position, these muscles are going to play a role. They can also play a role in terms of lateral flexion of the vertebrae. Now, these can be commonly strained, particularly if you improperly lift something. So I'm sure you may have heard the phrase, lift with your legs or your lower body, not your back. That's because if you improperly, kind of extend your back, that can cause soreness or, slight tears in your erector spinae muscles. There are three parts, three kind of categories of muscles in this region. You'll have the iliocostalis muscles, and you can see that there are different types of those. Don't worry about the cervicus or the thoracus. Just understand that the iliocostalis are typically the most lateral of the bunch. Longissimus tend to be kind of intermediate in terms of positioning, and the spinalis muscles are the medial most. They are very closely associated to the vertebrae. You can see that they can get broken down into extremely small but very important muscles there. I've heard the mnemonic "I love spaghetti" to kind of help in terms of remembering these. So the I is iliocostalis, is lateral, love is longissimus and middle, or towards the middle intermediate, and then spaghetti spinalis. And you can see there are these small muscles here. All right, the reason that I left latissimus dorsi to the last is that while it is very visible on the back, which is what we're talking about here, the neck and the back, it is this large muscle that makes up a good majority of this kind of more posterolateral portion of the back. It actually will extend and have its distal attachment on the humerus. And that's important because that means that this muscle will cross the shoulder joint and can have a direct effect in terms of the shoulder joint. So while it is certainly very clearly associated with the back and located on the back, it is not going to as directly affect the joints in that region. It can play a small role, but really its most forceful contractions will be associated with the shoulder joint or the glenohumeral joint. And so this muscle can extend the shoulder joint, so think kind of bringing the arm from a flex position back to anatomical position and even a little bit beyond that. Adduction, so back towards the midline and sometimes past the midline. And then medial rotation, if you think about having the anterior portion of the arm moving or rotating medially or towards the body. So that is what these this muscle will do. These muscles you'll do these types of movements quite a bit in swimming. And so individuals that are swimmers often have very robust or hypertrophied latissimus dorsi muscles. Now there are many, like I said, many muscles associated with the neck and the back. We went over some of the big picture muscles for the back and some of the big picture muscles for the neck. There are some smaller muscles associated with the pharynx or the pharyngeal muscles, as well as the larynx. And you will talk about those in more detail in the GI section of this course, as well as the respiratory section of this course. So, not that these aren't important and aren't big picture, they'll just be covered elsewhere. Okay, let's finish off this section with a question. So the muscle directly anterior to the subclavian artery has hypertrophied considerably and is compressing the subclavian artery. Which muscle is this? What is causing this compression? Is it the anterior scalene? B, the erector spinae? C, latissimus dorsi? D, sternocleidomastoid? And E, trapezius. Okay, so let's kind of work through this stem together. So we're looking for a muscle. These are all muscles, so that's not all that helpful. That is directly anterior, so not just anterior, but directly anterior to the subclavian artery. All right, the subclavian artery is going to be in the root of the neck, kind of right underneath the clavicle, so we need to be thinking more anterior neck region. And it's compressing this artery. So, anterior neck region. Which ones are going to be part of the anterior neck? Where the anterior scalene is, it has it right there in its name, and that is going to be a possibility. Erector spinae, no, that's deep back, that wouldn't make sense. Latissimus dorsi, the latissimus dorsi muscle belly is on the back, so no. Sternocleidomastoid, that's a possibility, because it is anterior lateral neck. Trapezius, no, that's going to be on the back as well. So we're left with these two. Sternocleidomastoid is going to be anterior, but it is not directly anterior to the subclavian artery. The anterior scalene sits almost right on top of the subclavian artery, and recall I said that that's the one that subdivides the artery into three parts. So if I return back to that image, you can see that anterior scalene right here. The sternocleidomastoid would be even more superficial to this region, so it is not directly anterior. Okay, So that was a lot of fun. We are going to keep moving inferiorly, focusing mainly on the axial portion. We'll save the appendages and the upper and lower limbs for last. And so keep at it as you're reviewing this material. If you have any questions, please feel free to reach out to me. I love questions. I love receiving questions early and often. Try not to leave things towards the end or closer to the assessment. Thank you again for your time and attention, and have a great rest of your day.